Good morning, everybody. Especially Dr. Rakesh Jadhav from India. Good morning. So I will discuss the scenarios. That is scenario-based. That is the issue discussion. That is the when to refer the cases for the EPS study. This is one of the example. That is the PVC. Possibly everybody will agree that this is the one of the commonest arrhythmia. It is prevalent nearly about 1% of the normal population, randomly done by the, that is can be detected by the 12-lead ECG, or we do the randomly halter. Nearly 50% of the patient may have, patient need, that is the normal population may have one or more, that is the PVCs, and coronary disease and DCM patient may have nearly 90% of the cases they have got the PVC. But question is symptomatic PVC, when to treat? It is the duties of the attending physician to do the initial workup of the PVC patient. That is the initial workup. There is the a light. So initial workup, that is the initial workup. It is the duties of the attending physician to do the every PVC cases, that is initial workup. That is the explain the symptoms, whether the palpitation, vertigo, loss of consciousness, or the cardiac arrest the patient had. PVC localization, there is the only lead V1 and 2, 3 IVF can give the answer. That is the left-sided or right-sided apical versus basal. These are the basic approach. Then the PVC burden that can be detected by the Holter, that is 1%, 2%, 20%, 30% like this. That is the 20. That is the PVC burden, the per 24 hours. Then the cardiac status, that is whether the patient has got the structural heart disease or not, and the coronary status, whether the ischemic and non-ischemic. This is the initial evaluation should be done. And after this, the physician should take decision whether this patient should be referred for the ablation or not, as because PVC ablation is recommended and is a beautiful result, and the suitable cases, that is the PVC can be, that is nicely ablated. So the significant patient should be referred for the ablation, and these are the situations, that is the normal heart, symptomatic patients, burden more than 15%, somebody says 10%, somebody says 20% like this. So there is a significant burden, and risk of the heart failure if the long-term PVC is present, significantly the patient may have the heart failure. So these are the cases. Not all the PVC cases should be referred for ablation. These are the situations that the physician can send the patient for the ablation. This is another situation. This is one of the common examples of the sustained, commonest sustained the arrhythmia, that is the atrial fibrillation. We know the atrial fibrillation, the objectives of the treatment of the atrial fibrillation, these three. That is that stroke prevention, rate control, rhythm control. These are the three objectives. When rate control, rhythm control, either two or one cannot be achieved by the medical management, then the physician can take the decision for the ablation. And we know there are three types of the arrhythmias. There is the paroxysmal, persistent, or the long-standing. In case of the paroxysmal atrial fibrillation, the indication of ablation is class 1 or class 2A. But in case of the persistent and long-standing, because of some of the issues, these are the class 2B indication. But in case of the paroxysmal atrial fibrillation, which is the commonest, this is the class 1 or class 2A indication. But before that, as because it is a class 1 or class 2A indication, but before that, every patient should be tried with the medical management. This is the first that is the first recommended management for the atrial fibrillation, and the treatment of the when the patient, that is when to refer the patient when there is a failure of the drugs, particularly class 1 or class 3 antiarrhythmic drug. And we have to be careful which antiarrhythmic drug should be given to which patient. And this question is given by the whether the patient has got the structural heart disease or not. When there is a structural heart disease, sotalol and amiodarone is the drug of choice. But if the patient does not have the structural heart disease, sotalol, propafenone, flecainide, or amiodarone can be given. And if the patient has got the 10% A burden with the ICD or CRT, that is the patient who has got the already ICD or CRT, but the atrial fibrillation burden is more than 10%, these are the candidates again can be referred for the ablation, or the patient who has got the atrial fibrillation with the heart failure. So not all the atrial fibrillation patients, these are the groups of the patients who should be referred for atrial fibrillation ablation. Atrial fibrillation ablation is recommended, class 1A, that is class 1 or 2A in case of the paraxial atrial fibrillation, class 2B for the persistent and long-standing atrial fibrillation. And we know there is the sources of the atrial fibrillation is the pulmonary veins. These are the pulmonary veins, that is the 4 pulmonary veins. The opening of the pulmonary vein, this junction, that is the junction of the pulmonary vein at the left end of the junction. These are the areas, these are the sources of the, these kinds of the, that is the multiple random, chaotic, that is the atrial rhythms, and these should be ablated, that is pulmonary vein isolation is the treatment, and these are the candidates who should be referred for the ablation. This is another scenario, that is the atrial flutter. This is rare in our clinical practice, but these are the very much characteristics, that is the atrial flutter, and there is no questions when this case is detected. These cases, all these cases, irrespective of the underlying structural heart disease or not, and most of the cases the atrial flutter patient has got some kinds of the atrial, that is a problem, that is a dilated atrium, some kinds of the structural heart disease. All these cases of atrial flutter should be referred for ablation, as because the success rate is very high, complication rate is very low, recurrence rate is very low. So these are the groups of the patient. All the cases of the atrial flutter should be referred for the ablation. And this is another case. That is the very characteristic ECG findings, and I think everybody will identify this is the Brugada type atrial, that is the ECG, and this is the type 1. That is the type 1 Brugada type. When these cases has got some of the criteria for the ICD, that is like this. That is this ECG with this documented polymorphic VT or VF, or the family history has got such kind of the, either of the family, any one of the member of the family has got these kinds of the ECG, or this patient has got the symptoms like the syncope or nocturnal agonal respiration. These groups of the patient is the classic indication for the ICD. So this is the duty of the attending physician. He gives the decision, yes, you need the ICD. But when this is the incidental diagnosis, without symptoms, the physician get these kinds of the what to do. These are the case, that is the asymptomatic patient, incidental diagnosis should be referred to the electrophysiologist. He will do the drug test or the EPS test to see the VT or VF and see whether the patient has got the high risk of the sudden death or is a candidate for the ICD or not. So this is the message, that is the not all the cases of the Brugada without these criteria should not be recommended for the ICD. Asymptomatic patient should be sent to the electrophysiologist for this study, and they will take the decision whether this patient will need the ICD or not. This is another group of the patient, that is the syncope. That is the cardiac syncope. Before, from the history, it is the duties of our, that is the way from the history we will decide whether the patient has got the cardiac syncope or non-cardiac syncope. If the syncope is cardiac, then we have to correlate with some of the findings, as because there is cardiac syncope, there is some clues before, that is from the history. As for example, if the patient has got the syncope with collapse, then that is a palpitation followed by syncope, it is likely that is the, and the collapse, it is the VT. Palpitation, syncope, no collapse, most likely it is the SVT. And from the ECG during the palpitation or the previous, that is records, we can get these kinds of the arrhythmias. This syncope patient has got these kinds of the arrhythmias or not. Or even the resting ECG may give some clues whether these kinds of the findings are present in the resting ECG. That is the ARVT, that is the epsilon sign or Brugada sign, QT abnormalities, LVAs or WBW. So these are the clues we can get before the sending the patient. If these clues are present, then we can take the decision, say what can be the mechanism of the syncope. But when all these are absent, but these are the signs, that is the 12-bit disease shows signs of the group beating, that is suggestive of the sixth channel syndrome. All the Holter shows these kinds of the process, that is not characteristic for the qualifying for the pacemaker indication. What to do? These are the groups of the patient. This should be actually undergoes the diagnostic EPS studies where there is the pacemaker indication not. So these groups of the patients sent to the EPS study for the electrophysiologist. So not all the syncope patients. There is another group of the patient who has got the syncope. That is the suspected case of the paroxysmal AV block. In this case, that is the patient has given only the history of the syncope. And similarly, there is no clues. ECG is normal, or the Holter is normal, echo is normal, but the patient has got the syncope or the recurrent syncope. We have carefully see that is the underlying ECG may give some clues. That is if the patient has got this syncope with this LBB, or these are the findings, that is the bundle branch block, or the patient has got the bundle branch block during the stress testing, or the patient has got the positive carotid sinus positive test, or the patient has got the positive tilt test. These are the clues in favor of the paroxysmal AV block, and these groups of the patient should be sent for the diagnostic EPS study whether there is indication for the pacemaker or not. And this is also another condition where the patient should be sent, that is the same the syncope patient, that is the diagnostic test. This is only for the diagnosis of this tilt test. The tilt test is done by usually by the electrophysiologist when there is a suspicion that the patient may have concerns, that is the syncope should be defined, whether it is the orthostatic or the vasovagal or it is the true organic, then this candidate should be sent for the diagnostic tilt test and sent to the electrophysiologist. This is another groups of the patient, that is the second degree AV block. Sometimes we are confused whether this qualifies for the pacemaker or not, and particularly when these patients are the asymptomatic, normal echo, and most of the time these are sent for the cardiac clearance before doing any procedure, surgical procedure, guiding or the surgery. So what to do? These are the groups of the patient. Before giving the answers, we are doing the EPS, that is the Holter test. The Holter test is also not conclusive. So these groups of the patient again can be sent to the electrophysiologist for the diagnostic EPS test. This is one of the example of the diagnostic EPS test. In case of the EPS test, we see the sinus node recovery time, ASV interval, or VT stim, that is VT stimulation. These three are the most commonly done in the EP lab in cases of the syncope to see the actually underlying mechanism of the syncope. So these are the candidates. This is one of the group, that is one of the examples of the patient. This is very characteristic ECG, that is RBB morphology, moderately wide QRS complex, left axis deviation. This is very classic sign for the ILVT. These groups of the patient, particularly these are actually diagnosed as the ILVT on the basis of some criteria. These are the actually fascicular VT, and these groups of the patient, all these patients should be sent for the EPS study as because ablation result is very excellent, recurrence rate is very low, success rate is very high, and complication is very low. So all these patients should be sent for the actual EPS study. Possibly no more time, na?
You have got 90 seconds more.
So this is another example. This is one of the, that is the idiopathic VT. There are three idiopathic VTs. That is the ILVT. This is the RVOT VT. Again, similarly, the RVOT VT, these kinds of the wide complex, that is LBB morphology VT, actually Poppy described. These groups of the patients should be differentiated from the ARVD. That is this is actually examples of the two kinds. That is either idiopathic RVOT VT or ARVD, and these are the actually tests by which we can differentiate between the RVOT VT and the ARVD. In case of the RVOT VT, the result of the ablation is very excellent, but in case of the ARVD, this patient should be sent for the ICD, and in all the situation should be sent to the electrophysiologist for the actually diagnosis and the management. This is another example, that is another example of the structurally normal heart, polymorphic VT. Again, the heart is structurally normal. This patient has got the polymorphic VT, and these kinds of the polymorphic VT, most of the time it is related with the channelopathy. This should be actually excluded by the cardiac MRI, and if the cardiac MRI is normal, this is the channelopathy, and we should be sent for the diagnosis and the treatment, particularly the ICDs. These are the scar VT. I think the time is over. These are the scar VT. Most of the time when the scar VT appears after the ICD implantation, should be sent for the, again, that is the ablation. That is the ablation of the ischemic VT result is good, And this is epicardial VT, again should be sent for the
Thank you, sir. It was a brilliant lecture.